Welcome back to the FOAMfrat podcast. Happy EMS week. By the time we post this, EMS week is going to be almost over. Hopefully, you guys have been watching our social media and you were able to win some cool prizes. If not, I guess this blog and podcast are going to be your consolation prize for the week. So this discussion, we're going to be talking about everything Laplace's law and Starling curve related. And this topic was born out of a class that I did in the live portion of our EMS and nursing refresher on congestive heart failure. If you guys haven't joined already, we do live classes 5 days a week, 3 times a day, twice on Friday. And we also have our library of over 100 hours of content for you guys to check out. So make sure you check that out and let's get the discussion started.
No rubber band, comma, man. And what was your thought? What was your framing with this, Sam?
I have had a bone to pick with that illustration for a long time. That whole, the ventricle is like a rubber band, because it's true, but like up to a point. And so there's another illustration that you guys will see in the blog that I recently used for a class for the live section for congestive heart failure. And so I was like, I'm going to build this out a little bit and I'm going to explain it like piece by piece. And so we go over the variables of, the cardiac output, and we talk about the systemic vascular resistance, the preload. We also talk about the inotropy, the strength of the ventricle and stuff. And so nobody's seen the illustration yet. It's not my illustration. It's an old illustration. But I'm curious, you took a look at it and it's a guy carrying a box on his back up a hill. And it talks about all these different variables. Did I change how you're going to illustrate it in the future, or are you still going with the rubber band? I want to know if I changed your mind.
No, I've never been a big fan of the rubber band myself. Like you said, you reach diminishing returns when it comes to the explanation. I really like your illustration. It makes sense. You got this guy walking up a hill, and there's variables. There's how strong is the guy? There's what's the incline, and then what's the load that he's carrying. And yeah, you could say, well, his goal is to get to the top of that ramp and drop those boxes off at the end of it. And if you were trying to see how many boxes you could get to pile up over a certain period of time, he probably could carry more than one, all right? And then he probably could carry more than two, but where is that diminishing return? And then you correlated that very well with the Frank-Starling curve, where adding preload, adding volume during diastolic filling is going to increase your stroke volume up into a certain point, and then you plateau, and then you actually get diminishing returns where you actually start to go into heart failure. And I love that, because that's the question. I mean, that's the $1 million question is giving my patient volume going to increase their stroke volume and thus their cardiac output? And, we've seen so many changes in the way that we postulate if this occurs. So remember, we were looking at IVCs for a while, and a big thick IVC, that's got to be good, right? And then we were like, no, that's actually a pathological state. Well, if the IVC is collapsing, maybe that means that we could give them some volume. Yeah, but it also could be a normal state. That doesn't really tell us anything. So we've seen all of these weird things that have popped up as far as trying to determine, is my patient going to increase their stroke volume if I give them some volume? And you talk about the Laplace, however you say that, law. You talked about the Frank-Starling curve. And even though, like, my head, how I do with numbers, it's like, oh my God, there's so many variables here. A functional understanding of those things really puts this all together.
Yeah, I tried to really build that illustration, which again, it's not mine. I think that illustration is super, super old, but I don't know why it fell out of favor, and we kind of started simplifying it into just using the rubber band thing. But just to kind of catch people up who haven't seen it, or if you haven't looked at the blog by the time you're watching this, the guy carrying the box up the hill, basically the strength of his legs was the intrinsic strength of the ventricle. So it's kind of like ventricular health. And we know that can be influenced by stuff like, acidosis or electrolytes or cardiodepressant drugs or whatever, an infarction, whatever. And then you also had the load on his back, with the load that he was carrying was essentially the preload that he had to deal with. And then the slope of the hill. how steep it was illustrated the afterload. And so if it was super steep, that would be like a ton of afterload that he was dealing with. I didn't have too much of a good illustration for the Laplace's law, but I did build that curling thing, and that talked about a ventricle that was maxed out, and they're measured in the wall tension of the ventricle, and the force that it's applying is measured in these things called dynes per centimeter squared, which sounds super confusing, but it's essentially just like it has to be a squared equation because you're taking into account like this 3D portion, this like cubed portion of muscle. And so it was like dynes per centimeter squared. And then there was a certain amount there. And you divided that by the radius of the ventricle at diastole. And that gave you essentially a systolic blood pressure. And that measured this ventricular wall tension, right? Now, I don't know what, like I mentioned in the blog, like I don't know what you could use that for, but like technically you could get that number if you wanted to. But the way I tried to illustrate that, because that was something I was trying to come up with something different with. And the thing that I could think of best is like cheat reps versus strict reps with like, just to say like a simple exercise, like a curl. Like when your arm is straight out, like that is the most difficult way, that this most difficult position to break from, like I'm trying to learn one arm chin-ups right now, and I still can't do one because it's incredibly difficult. But what they will try to train you to do is to practice from a dead hang, because that's the hardest position to pull from, is to break the elbow once it's maximally stretched, right? So if I started with my arm already flexed, my arm already in a curl position, that would be much easier to move in a mid-range of motion. Same thing with the heart. It's very easy for it to move in a mid-range of motion. But if you stretch it to the max, that's when it has the most difficult time contracting. Just like it's hard to do a strict rep and break the elbow on like a curl or a chin up or something like that from a dead hang. It's the same thing with the heart. And so I tried to illustrate that the best I could. My whole reason in using that wall tension formula and Laplace's law was to show that if your ventricle is squeezing as hard as it can, as you increase the radius, in other words, make it more wide, the pressure that it's able to exert goes down. And so it was kind of like the Starling curve where you saw the response, but then you can actually quantify that with Laplace's law. And it makes a lot more sense if we'll post the graphics up here, but it makes a lot more sense when you look at it like, okay, it's the strength is maxed out, but as if you stretch it further from there, it becomes less and less efficient.
No, that makes a lot of sense. Why do we care about wall tension? What's the deal with wall tension? What's the clinical application to that?
Yeah, so wall tension, it's not the main driver. It really depends what you read. Like people say the main driver of myocardial oxygen consumption is essentially rate. You think about like rate is also, think about driving the splitter into that, AAA or something like that. Just like that's like the main contributor of, is that thing going to get worse or better? Rate is also usually tied with like the main contributor of oxygen consumption, which is why you see people give rate controlling agents if they want to maintain oxygenation in the myocardium or something like that during ischemia or a STEMI, whatever, But wall tension is also a humongous contributor. And so how tense that wall is, you can think about it if we go back to like a exercise illustration. You can think about rock climbing or something like that. If you ever went like rock climbing at one of those indoor places or something, your forearms get really, really tired, right? And it's because they're just tensed. It's not like you're doing like concentric and eccentric movements with your forearms. They're just very tense and they're doing like a static movement, It's kind of like wall tension in that way. And so when those walls are always tense inside that myocardium, it's like flexing a muscle and keeping it flexed. And that uses up a ton of oxygen. So rate and the tension of that wall are big contributing factors to like how much oxygen that wall is using, which can be good to know in some way if you're having some kind of ischemia.
Yeah, so I think of that like, you have two causes of that really. You have like a cardiomyopathy, like a hypertrophic cardiomyopathy, where you actually have an increase in the muscle. And then you also have the LV that's distended because ejection fraction drops. And that's going to create wall tension as well. Am I right in that thinking?
Yeah. Yeah. Both of those.
Yeah. So if those are two causes of a tense LV, how could I identify that that may be the case in this patient? And so, I think the answer that comes to my head obviously is ultrasound and looking at how easy the LV, or I should say, how the lusitropy of the LV during diastole. And so I wrote in the peer review of your blog, there's something called E-point septal separation that we were discussing. And it's interesting because the mitral valve opens up twice in diastole. And the first time it opens up, it's just because there's a situation where the left ventricular pressure is less than the left atrial pressure. And that causes this like passive filling. And you see this on ultrasound. If you drop your M line, you'll see this as a wave. The first one is the E wave, and that's just passive filling from a pressure differentiation. And then you have the A wave after that, and that's the actual atrial kick right before systole. And so what's interesting is that E wave is correlated with how relaxed your heart is. So if you have a really tense LV, that pressure differentiation between the left atrium and the left ventricle is going to be smaller. You're going to have a smaller gradient. And so you're not going to see that mitral valve flop open as much and get close to the septum. So you're looking at the relationship of the mitral valve to the septum. And that first E wave is just that passive filling, and you can get a good idea at how well the heart relaxes. And I think that that's really interesting because when we were at that ultrasound class at Hennepin a few weeks ago, they said that the heart naturally loses the ability to relax as you get older. And so you actually start to see your E wave initially in younger people is really high. And then you start to see your A wave actually get higher than your E wave as somebody gets older. And so when I was reading about the wall tension, I was thinking, all right, well, there's probably two different types of situations. There's probably more, but the two types I think of are a hypertrophic cardiomyopathy and then a patient whose ejection fraction drops and their LV is fat, it's big, and that pressure differentiation is going to be, a lot less. And so you're not going to see that big E wave. So that would probably be a great way to identify that in a patient that you're wondering, and we'll get into this in just a minute, like you see a pulse pressure that's narrow and you're wondering, is that pulse pressure because the systemic vascular resistance is so high? Or is that pulse pressure narrow because I'm actually just not ejecting enough volume out of my left ventricle?
Yeah, that's really typical of you to ask a question like that. So what happens is I write a blog on a very specific thing, and then Tyler comes out of left field with a really hard question, and then we debate it for 3 hours. And but we had a really awesome discussion this morning, and Tyler had posted a graph asking people what I don't remember what the exact question was. I'm not going to look it up on my phone, but essentially, like which one of these patients?
I said which patient would be fluid responsive. Yeah.
Right. And then he had like a different amount of left ventricular end diastolic pressure. And then there's also like the systolic blood pressure on top of it. And then next to it was a graph. You guys, I'm sure we'll throw it in the blog or something or on the screen. But it was also the other thing next to it was systemic vascular resistance. And there was a patient that had a wide pulse pressure and then a couple that had narrow pulse pressures. And thinking about which one of those is going to be the most volume responsive or not responsive is a tough thing, because when I was going through this blog, as I was telling you before the podcast, when I say that, we're trying to figure out where, because if we go back to volume responsiveness, because that was like mostly the point of this blog. I mean, that the wall tension thing was kind of a side tangent, something, this kind of a thought experiment, but mainly it's about how do we respond to differences in volumes, and is this patient volume responsive and that kind of stuff. So if we go back to that and we say, okay, this patient is volume responsive, what does that mean? Does that mean that their pulse pressure is widening, and so they've got a healthier ejection fraction, so they responded positively to that? Or are we just looking at a mean arterial pressure? Are we looking at diastolic volume, since that's kind of like the status quo in the circulatory system, where it's like that's, we got that baseline diastolic pressure that's perfusing back into the heart. And so it's actually a tough question. And I think when I was writing that blog, I didn't much think about that. I was just assuming maybe in my head that, well, if they're getting better, they're getting better. Maybe their pulse, maybe their blood pressure is just improving or something. Maybe you're using MAP or whatever. But then you brought up the question of, well, what about pulse pressures? If when you're trying to identify if this patient's on a certain point on this Starling curve, are you looking at a patient with a low pulse pressure, a high pulse pressure, and does that matter? And could you use that to identify if they're on the dark side of that Starling curve, where they're no longer fluid responsive? And so I can't remember which patient was A, B, and C right now, as I'm not looking at the graph. But which patients did we decide was not a candidate for fluid? I feel like we should start with that patient.
Yeah, so let's start off with that one. I got it right here on my phone. So B has a elevated left ventricular end diastolic pressure. So if you were to look at B on ultrasound, you would see that the heart is full of blood. It's not ejecting volume. And it's likely that that patient's going to have an elevated systemic vascular resistance because they're trying to compensate. So you're going to get that normal catecholamine surge and you're going to constrict. Now, the pulse pressure on B and C is exactly the same. And we'll say the systolic is exactly the same as well. And so that is where you need to make a differentiation. So you have a narrow pulse pressure. On B, it's because you actually have poor ejection fraction, where on C, it's because you have really low volume during diastolic filling. But they both present with the same pulse pressure, and we'll say the same systolic to just make all things equal. Mm-hmm. So that's where B and C were.
Yeah, so that's a really important differentiation, because one is essentially cardiogenic shock. B, and if I'm remembering correctly, in the middle is like cardiogenic shock, essentially, where, yeah, like you said, they got a really poor ejection fraction. That's the reason why that systolic blood pressure isn't coming much over, like, essentially the diastolic blood pressure, creating a very narrow pulse pressure. That's one thing. And like Tyler said, if you look at that ventricle on ultrasound, probably going to be very dilated. But on the other hand, you have a patient that looks very similar at C, but they're going to have a very small amount of blood in their left ventricle, even if the pressure is high, because pressure and volume are not always perfectly related. So if that systemic vascular resistance is super high, which is going to be in both of those patients, but in that C patient, that systemic vascular resistance is creating a lot of pressure in the left ventricle, but everything is just trying to squeeze down on a very small amount of blood. And so even if there's a large amount of systole and a large ejection fraction, the volume just is not there for it to move forward. And that's C's reason why they don't have a very large pulse pressure. Now, B, the cardiogenic shock patient, that is not a patient that you want to give fluid to, because you're going to look at the heart, it's already being full of fluid. The problem is they can't squeeze it. In B, on the other hand, that patient probably has a very small amount of fluid in their ventricle, and they're probably on the very beginning stages of that Starling curve, where they would, as that ventricle is stretched more, it will give you more contraction back. But the problem is they both got narrow pulse pressures. They're both probably clammy. They both got, difficult to palpate radial pulses. But one person's heart is full and the other one's empty. So that's a difficult differentiation. And then just for a sense of completeness, we should talk about A real quick.
Yeah. So A has we'll say a normal left ventricular end diastolic pressure. And I think maybe on this graph, it's probably a little misleading because it's smaller than normal. But the thing is you have a wider pulse pressure. And so this patient is likely, I think the way to say this is fluid tolerant. They're likely there's not going to be any badness from giving this patient fluid. Now, regarding that there's not venous congestion or other things going on in the body, if we're just purely talking about the heart, this patient's likely going to be fluid tolerant, whereas B would not be fluid tolerant. And then right. C would probably be most likely to be fluid responsive. Now, it's interesting because I have left ventricular end diastolic pressure and SVR. These aren't numbers that we have, right? So all we're going to see in the field, if we don't have a Swan catheter in or whatever, is we're going to see the pulse pressure. And so I know as much as we hate lines and throwing out random numbers, we keep seeing the number 25 come up as far as a pulse pressure. So you have a patient who's got a pulse pressure and we'll say it's less than 25. The next move is likely to pick up the ultrasound probe and look at the actual left ventricle. Would you agree with that?
Yeah, I do, because I'm on the same page with you. I hate those lines drawn in the sand, because when you look that up, and we were looking at a CV physiology book this morning before this, it was saying if it's below 25, think cardiogenic shock for the pulse pressure, and then if it's and obviously these patients are all hypotensive, narrow pulse pressure, and that pulse pressure is really narrow, like it's below 25 millimeters of mercury. Think that cardiogenic version. And then if it's, it's kind of narrow, they're still hypotensive, and, it's above about 25, then maybe it's just because of severe hypovolemia in some way, and that person would be fluid responsive. So there are some, and I'll put a link to that in the blog. But yeah, there's some approximate lines, but I could see either scenario where they could mimic each other. So I think the question is, if you have a good pulse pressure, I think the patient is probably fluid tolerant. We were trying to break this down before, like a way to simply say this. If the pulse pressure is good, like it's wide, it doesn't seem very narrow to you, the patient's at least probably fluid tolerant. And you could try a trial to see where it goes. It probably wouldn't be dangerous. Would you agree with that statement?
Yeah, and it doesn't have to be volume. I mean, there's like passive leg raises and things you can do to see if they'll increase their cardiac output.
Sure. And then we have the patients with the narrow pulse pressure. Those are the patients that are hard to differentiate. Clinical picture might point you towards one or another. If this is obviously a hypovolemic or trauma patient and they have narrow pulse pressures, well, go figure, it's probably because they have a really low blood volume. But if you got an undifferentiated patient where, maybe there's some medical stuff in nature, you're not quite sure if this patient has internal bleeding somewhere that you can't see with a fast exam or whatever, that's going to be the patients that's really hard to differentiate. But the heart is probably where you're going to pick that up the best at. And I think that's where the assessment of the volume in the ventricle is going to come in play and tell you, well, it could be low volume or it could be high volume. But either one, you just want to be, I think maybe the take-home message is that for at least this pulse pressure thing, is if you have a hypotensive patient with a low pulse pressure, you have to be cautious, because that patient could be very responsive to fluid, or they could be not that fluid for them could be the absolute wrong thing. So another use case for ultrasound. But if you don't, you should probably be careful with that first fluid bolus, or like you said, try fluid responsiveness a different way. Whatever your flavor of the week is, hepatojugular reflex or a passive leg raise, or like whatever it is that you're going to do, whatever is in your toolkit to figure out, like, well, maybe let's just try this first. If the clinical picture is really leading you to think this patient's undifferentiated at this point.
Yeah, and you could probably skip even looking at pulse pressure and just look at the heart on ultrasound. And if you see a hyperdynamic heart and you see clear lungs, and I always like to put lungs into that as well, because you want to make sure that the lungs are dry. And if they're not, you want to try to differentiate whether that's from a cardiac cause or not. But looking at the heart, you already got it on there. Look at the lungs, look at the IVC, and then you take all these data points together and say, hey, this patient may benefit from 250 mLs of fluid, and you try that out and you see. And if not, and they don't respond to it, and that gives you a little idea where they're starting at on that curve. But I don't routinely sit there and look at pulse pressure, but I do routinely throw the probe on the heart. And if I look and it's hyperdynamic and I see our ejection fraction's 90%, that patient is likely going to benefit from some volume. And it's just another feather in the cap of ultrasound. I mean, we can sit here and we can try guessing all of this stuff, or we can actually know by looking at the heart.
Yeah, I think that's perfect for those. So I think that's a great point. And I feel like pulse pressure too is something that you usually notice if it's really out of whack.
Mm-hmm.
Like I would suspect very few people are looking at their blood pressures and figuring out their pulse pressure real quick. Maybe you eyeball it sometimes or kind of estimate it in your head. But I don't think many people are saying like, oh, it's less than 25% of my systolic. And, I think very few people are probably looking at that. But if it does seem alarming, that might trigger further investigation if you're planning on giving that patient volume, or if you think they might be indicated for it. In the absence of, so ultrasound, that's great. If you have ultrasound, you're going to be probably, what would be your approach to that? So you're just looking at a parasternal short axis at maybe the level of the papillary muscles, or like where are you looking at, on a parasternal short axis to look at the circumference? Is that pretty much what you're doing? Or are you using a long axis because you prefer it? What's going to be your approach to determine, is this ventricle underfilled or overfilled?
Yeah, I'm going to do a parasternal long, and then I'm going to look at the movement of the mitral valve in relationship to the septum. And that's what I've built the majority of my mental model around, is that parasternal long. And then because it's so easy, I'll drop an M line down the tip of the mitral valve, and I'll just get an E point septal separation and measure out the E wave in relationship to where the septum is. Take a picture of that. I really only use short axis if I'm looking for wall motion abnormalities or maybe something weird with the aorta. But as far as just a quick look, you're doing your rush exam, you're trying to figure out why your patient's hypotensive, throw in that parasternal long, which is probe marker towards the right shoulder in the cardiac mode, is my preferred way of doing that.
All right. So let's say that's pretty easy. So the order of operations would be, you have this patient that maybe they seem a little bit undifferentiated. You're wondering if they're fluid responsive. You've obtained your baseline set of vitals. You've identified that this patient is hypotensive, and maybe the pulse pressure seems kind of narrow. And you're like, I wonder what we should do with this patient. They seem like their pulse pressure is narrow, blood pressure isn't that great. We're either going to be moving forward with an inopressor probably, or some fluid. Let me throw the probe on the heart, parasternal long axis. Does it look like it's ejecting a lot? You're doing the E-point septal separation to assess the contractility of that ventricle. What if somebody threw your ultrasound in the trash and said, here's this undifferentiated patient. The clinical picture is kind of confusing. You're not quite sure if this is really bad hypovolemia or if this patient is in cardiogenic shock. Besides lungs, because that's kind of the low-hanging fruit there, right? Unless they have like a direct lung injury or something like that, like they shouldn't be full of rails, right? Absent the lungs, what would be your next move? You got this patient that's hypotensive, undifferentiated if it's cardiogenic or hypovolemic, and you're trying to figure out, why does this patient have, are they going to be fluid responsive? They have a narrow pulse pressure, and they're also hypotensive. What's your next move if you don't have the ultrasound?
Yeah, so both of those patients are going to present with probably an elevated and systemic vascular resistance. So their SVR is going to be high on both of them. So it's not like you can use things like, cool and clammy skin, because that's probably going to be there either way. I'd say at that point, you really got to go off of history, So is this a patient that just got done running a marathon, or a patient that was septic? Or is this a patient that's got, big swollen ankles and they're on furosemide and they've had a history of an MI? I mean, that's really going to lead you down, because, they look similar when you put their hemodynamic profiles and their pulse pressure next to each other. But in reality, like, that patient who's going to benefit from volume, like, they probably had some sort of volume loss, or they had systemic vasodilation from sepsis. And that patient's not going to have likely an elevated SVR unless they're on pressors and stuff. So at that point, I'm going to have to go, I want to say old school, but I'm going to have to really start looking at the clinical context in which I'm evaluating them in. I look at everybody's ankles. I'm a big ankle guy, but I feel like I knew that was coming. But I feel like looking at that type of, like, looking at those clinical signs that tell you that this patient is fluid overloaded is going to point you in the right direction. What would you do?
I think too, sometimes the best way to evaluate if somebody is, I agree with everything you said, and absolutely. And I think that will steer most people in the right direction. But I think if you're really unsure, sometimes the best way to figure out if somebody will tolerate a little bit of fluid is to give them a little bit of fluid. Because if it is a cardiogenic shock and I accidentally just gave
waterboard Ireland.
Well, what? Yeah, because if it is a little bit too much, then you should probably just have a pressor ready either way. If they're hypertensive You're not going to give them fluids. You're not worried about this giving the SCAPE patient fluid where you're going to have to like reduce that with nitro or something like that. And so if you have a hypotensive patient, you should have the ability to start a pressor, whether in this patient, probably norepinephrine. You should have the ability to administer some epinephrine rapidly. And 250 shouldn't make like a screaming world of difference. And so if you notice that they're like getting worse, that doesn't seem like the right thing, it's probably time to stop and try a pressor if they're truly that undifferentiated, where you can't tell the difference if this is hypovolemia or if this is cardiogenic shock, which is a strange place to be if the patient is truly that difficult to tell the difference between.
Awesome, man. Great post. Anything else we should add?
Somebody needs to come up with a use case for measuring wall tension, because I can't. It's such a cool thing. Like, hey, like you want to measure something in dynes per centimeter squared? Like, hey, be my guest. You can estimate it over here, but I can't think of what it's useful for. So I need somebody smarter than me to tell me why we'd even use that number. But it was a cool thought experiment. I was actually really excited to put those numbers and that graph together because I thought it was super cool, but I don't know what to do with it.
Yeah, I was also wondering if there's a use for pleth wave for looking at pulse pressure.
The other thing would be pulse. If the patient's positively pressure ventilated, you could look at pulse pressure variation on like an art line too. If you were like in a more critical care setting, that might tell you a little bit as well. But you probably have a lot of monitoring in that case. So you're probably going based off of more than just pulse pressure variation.
Awesome, man. All right. Well, if you guys have any questions, hit us up at team@FOAMfrat.com. Make sure you check out the post. Awesome illustrations as always. And we'll see you guys next time.
See you guys.